Again, good morning, everyone. I'm Cherie Strong, and that's Monique Owens. And today we'll be presenting Working with Families in Crisis. Thank you for being here. Thank you, Summer, for handling the behind the scenes tech stuff. So far, so good. Again, we're talking about working with families in crisis. Monique and I are here because we are experts in what it's like to have family traumatized by a mental illness of a relative. We both have lived experiences in which we have used and are using to create a community of information, support, awareness, and purpose. 1 in 5 families in the United States and in the world are affected by serious mental illness. Our families are represented in that number, and many of yours are too. Our expertise comes from a personal experience and also that of many families we have come in contact with through NAMI. Here's Monique introducing you to her family.
Thanks, Sharice. Good morning, everyone. And I am so grateful for this opportunity to share a snippet of this journey with you from a family member's perspective. As you can see on the screen, there's in the upper right hand corner is a picture of myself and my 6 children. That was a few years ago. They're all adults now. And a picture of my daughter Brandy with her father. And then there's a picture over there that it's kind of painful to look at, but okay. One of the things we didn't do is precursor you that we will probably get emotional during this presentation. So we will be doing a lot of reading. So please forgive us if you see us reading a lot, but that's to help us process through the emotion and to keep us on track. Okay, so that was a sidebar. But the picture there that is emotional for me was when Brandy was incarcerated. And that was the only way we could talk to her. So I'm going to get myself together. I'm sorry. So I'm grateful for this opportunity to share a snippet of this journey with you from a family member's perspective. I'm a divorced mom of 6 and grandmother of 8, where many of us have various diagnoses. However, I will share a portion of Brandy's story. She's been living with symptoms of bipolar disorder, post-traumatic stress disorder, and ADHD for 16 years. She is the 3rd child, and as a youngster, let me calm down. And as a youngster, had an abundance of energy and friends, loved dancing, singing, cheerleading, travel, and popularity everywhere she went. She did well in school, loves children and animals, and dreamed of becoming a veterinarian. However, life took a turn for us as she approached adolescence. Her behavior became extremely impulsive and her thinking irrational. My once pleasant child was now starting to disobey rules, go missing days at a time, disrespectful to her teachers, and defy all authority. The drastic change became alarming to all who knew her. Assuming it was just bad behavior and that she would snap out of it, whatever it was, I had exhausted resources. Okay, I'm going to get it together. I had exhausted resources that were designed to get her help as a teenager before she got in trouble with the law, but nothing was effective. Out of desperation, I took her to the police station in hopes of a scared straight moment. The officer was very compliant with my request, ironically. But from the lobby, behind the glass, 3 doors down, and with the door closed, I could hear her yelling back at the police officer. I just knew she was about to be arrested for sure. So imagine my demeanor when the officer emerges with this flustered look on his face, shaking his head and says, "Ma'am, you have something on your hands with this one." My quick retort was something I dare not say right now. Feeling helpless and defeated, I asked, "What do I do now?" He says, "You know, corporal punishment is legal in Maryland. And unless she gets in trouble with the law, and unless she gets in trouble with the law, there's nothing that can be done to help her." Unfortunately, he wasn't kidding. The last 10 years contained severe mood swings where her depressed states were just as alarming as her manic. Her self destruction and reckless abandonment had me so frazzled with worry that the stress landed me in the hospital too many times. The family didn't trust her and walked on eggshells when she was around because of her erratic behavior. We just wanted our sweet little girl back. It broke my heart when she asked me one day with tears flowing, "What's wrong with me, Mom? Why can't I get this right? I don't want to live like this anymore." I felt my little girl slipping away. I felt like I was failing her. As you guessed it, the most bizarre behavior she ever experienced landed her in trouble with the law. Our uneducated selves didn't know that she was in the middle of a psychotic episode. Although later we had an explanation, there was no excuse for the crime. Once it was discovered that mental illness was involved, we had a much different experience. She did her time, paid her restitution, received treatment, and is recovering very well. The judge, police officers, and employers were very helpful in this process. By this time I was introduced to NAMI family to family. This saved our lives in so many ways because I realized I wasn't alone. There are other families suffering just like mine. Although the diagnoses were different, we all shared the turmoil and life disruption that will now be our new normal. Through NAMI's education, I understood that mental illness affects more than the person with the diagnosis. It grips entire families, damaging relationships, depleting resources, and crushing hopes and dreams. Our family has an amazing support system in place now. We have educated her friends, boyfriend, family, and even her employers. So when they see a change in her, we all leap into place. This knowledge has been effective to ensure police involvement is not necessary. Please believe me that education is key. I have dedicated many years of volunteering to educate families in crisis through family support group, family to family, and basic sessions. Thank you for your attentively listening to my experience. And I apologize for the tears, but thank you
Oh,
so much.
Monique, please don't apologize. That was excellent. Thank you for sharing. Thank you for sharing. So, um, attendees, we have Latanya Eggleston, who is our moderator. And Latanya has joined us after having a little bit of technical difficulties. We know how that is. So, hello, Latanya.
Hi, Latanya.
Not able to hear you yet, Latanya. All right. So, how, not yet, Latanya. No problem. No problem. So, what I'll do is, Latanya, well, can I, one more time, Latanya?
Sure. Testing
Yep,
one,
I
two,
can hear
three.
you. Yep, very good. Thank
Yay.
you.
Monique, thank you. I was here for that entire piece. So I want to thank you so much. And in the chat, I have been noticing, in spite of technical difficulties, people saying you don't have to apologize. Thank you for sharing you and being your authentic self. So we appreciate the participation. And we definitely want to welcome each one of you to this 40th annual conference. And I am a volunteer and board member with NAMI Maryland. And so please continue. We're going to keep the program going. And just reminding everyone, if you need closed caption, it is available. If you have not located that, that session or option is available to you. We do have to verbally say to enable captioning, please just click on the CC icon below the display of our presenters. And once you click on that, the video will display, will become a little smaller, and you will see the captions being generated underneath. Comments, concerns, any technical difficulties, just go ahead and put them in our chat. We have technical assistants that are on standby and we'll address them accordingly. So I appreciate them. So I want to thank again Monique Owens for your amazing sharing and openness, and Cherie Strong for being a part of this workshop today. Continue to put your questions and answers in the Q&A section on the right hand of your screen, and I will read those questions at the end, and our panelists will be able to articulate and communicate or respond to them for you. So thank you. We'll continue.
You're on
Okay,
mute, Sharice. There you
okay,
go.
I'm sorry. All right, so we'll go continue again. My name is Cherie Strong. So today's workshop is very personal to me. My oldest son was in his junior year at Bowie State University when he experienced his first mental illness breakdown, a psychosis. He had no prior criminal history, had never done drugs or alcohol, kept a steady job at Safeway and Sears since he was 16 years old. He's very much like myself, an introvert, stayed to himself, he likes to draw, and aspires to be an architect. One weekend, while home from college, he started having delusions and was found outside a school. He was naked. I should note a few days before that, he started not acting like himself. He would come to my room and talk a lot. Their stories were mostly of family, God, and people at his job. He wouldn't stop talking, which was the exact opposite of who he is. He's very quiet. Most of the stories ended with him thinking he was being chased, followed, or being talked about. He couldn't sleep either. I later learned these were signs of paranoia. A citizen saw him at the school, knew something was wrong, and gave him her coat. She stayed with him because, as she described it, he was confused and he was afraid. She notified the police to get him help. And I'm not sure what happened between the ride from the school to where he was found, to the hospital, to where he was dropped off. But when I arrived at the hospital that evening, my son, he was tied up, he was beaten, and his face was swollen. In my profession, I'm a network engineer. And at that time, I ran the computer network for the same hospital that they brought him to. So I had a lot of internal connections, and my badge access gave me access to everywhere in the hospital. I walked into the emergency room, and my heart completely broke. I can still remember his eyes looking at me, all budgy, bulgy, teary. He was so afraid. He didn't even know why he was there or what had happened, and I didn't either. I heard the ER nurse tell one of the other nurses that he believed the boy in the room, so and so, had schizophrenia. After making some internal contacts with nursing staff, I was able to find a mental facility to get him transferred and checked out. And weeks later, while in a mental facility, my son was diagnosed with bipolar and schizophrenia. My son got the treatment and care that he needed and was given the program to continue, and he went back to Bowie State and eventually graduated. I was, and I still am, so proud of him. This outcome, unfortunately, doesn't happen with everyone, especially those who do not have the internal connects or access to internal information like I did. During that same time, as he was receiving treatment and care, he was also receiving letters that he had to go to court from that same incident. We had no idea what was before us. We didn't even hire a lawyer. Since he was in psychosis, he didn't know what had happened that night, and I naively assumed that this was nothing more than a mental illness issue. And now he was getting help, and it was over, right? No one was hurt, only him, right? Well, we walked into that courtroom, we sat down, and then heard the words that scared the life out of my son and I. Your Honor, we, the state, are asking for 7 years of prison time. Our hearts literally dropped. We were empty, scared, didn't know what to do or to expect. How in the world could this be happening? We were unprepared. I couldn't imagine my son, who had never gotten in trouble, very quiet person, pretty good kid, was doing well at Bowie State University, was now facing 7 years of prison time simply because he had a mental disorder and the officer didn't know how to properly respond to it. This is why CIT training is critical and much needed, right? My son's case was eventually thrown out completely after I had to make an emergency call to another internal connect. But unfortunately, for far too many, it doesn't happen like this. Just that quick, he would have been thrown in jail for 7 years. Afterward, he went back to Bowie State. He got his degree. He started working at the State House and started his own nonprofit called Stop the Stigma. He still has his challenges. Since then, he's had a few other setbacks due to his mental condition. But now that we're now more equipped as a family and have learned and still are learning so much. As you all probably already know this in this meeting today, 1 in 4 people with a serious mental illness are arrested during their lives. 2 in 5 adults in jail or are in jail or in prison have diagnosed mental illnesses. 7 in 10 youth in juvenile justice systems have a mental illness. And that's why I joined NAMI and advocate, because NAMI fights for policies to give people help and not handcuffs, right? And this includes expanding access to crisis services and promoting best practices in de-escalation and diversion of people experiencing psychiatric crisis to treatment. So now you learn a little bit about us. You got our little tears out. That's our story, and I know that you all have your own stories, and we empathize with you. So let's go ahead and get started with the presentation. Monique?
All right. Sharice, thanks so much. Every time I hear your story, I still get emotional just like you do. And I'm just grateful that we get to share this platform together. Oh, so now we got to get ourselves together and do this presentation. So y'all pray for us, okay? All right. So laying the groundwork, families dealing with mental illness. We, the family, are often the caregivers of last resort. When all else fails in the community, the family, even reluctant ones, will frequently take the ill relative back into the family home. Families do this with no training and little information about mental illness. 65% of patients are released from the psychiatric units to their families, and yet families receive little information or support. Board and care providers and mental health workers have made a choice to go into the mental health field, but families aren't given a choice. We have to do the best we can many times, not even knowing where to begin. Families are often not told about other options like mental health crisis agencies such as BCRI in Baltimore City or the crisis system in Baltimore County. And so we call the police. Families wait to call 911. By the time the family calls the police, everything feels out of control. We might have been dealing with things for a long time. We may have been fighting for weeks and may not have gotten sleep for days. We feel that the police are going to be the last resort and that they are equipped to solve the problem. At first, families think that if we can just get the person in the hospital, everything will be okay. So we do an emergency petition or call 911. Then as we all know, they are often released the next day. You know, the proverbial revolving door. We are frustrated and angry at the mental health system for not fixing the problem. Then we may be angry at the police officers who came to the door and cannot solve the problem. Sometimes the family members will appear to be the hysterical parties while the ill person is lounging on the couch watching TV. It's not uncommon for the family member to be the one who is agitated and irritable when the police come. All right, something. Okay. So, what constitutes a crisis for the families? People are told to call the police by psychiatrists, mental health workers, by friends and neighbors, to dial 911 after hours for emergencies if the subject gets out of control or if things escalate. We expect officers who have been extensively trained in mental illness whose sole concern is to get the subject to treatment. We, the family, are rarely told what level of emergency or crisis or escalation is considered sufficient for mental health professionals or for police to intervene. We may call when there is not a crisis sufficient to take the person to the hospital, or we may call when things have escalated way out of control. Lots of things constitute an emergency to the family, and one happens to be heading off or preventing major relapse that we see coming from our past experience. A study about 10 years ago demonstrated that family members could accurately predict the relapse of their ill relative as much as 2 weeks before it occurred, based on idiosyncratic behaviors and symptoms. So it is imperative that we must intervene now before the inevitable occurs. On the other hand, sometimes we often have gotten used to escalating or intolerable situations that we normally wouldn't tolerate, because that is what happens when you are dealing with the behavioral symptoms that come with psychiatric illness. Or the family is in various stages of denial and is just hoping that their relative will just snap out of it. We don't want to call the police for minor problems. Generally, by the time the family takes the step to deal with a crisis situation, there is no easy solution. No one wants to call the police for their relative. We are often afraid that things will escalate. We may have had previous experience with police. They came and left, and things got worse. We don't want our relative to get hurt or to hurt anyone else. We're all frustrated, police and families. We often really have the same need in the end to get the person treatment that works so we don't have to deal with the roller coaster of decompensation and crisis behavior. We need to be partners in getting treatment and in advocating to improve a system that doesn't always work well. Families can be a very useful resource to emergency responders. Families have a lot of useful information about the person's history, medication, current treatment, history of violence, etc. Families generally know what has worked and what has not worked in the past crisis encounters, what scares or sets off someone, and what interests or concerns you may be able to use to engage the person. Families are often the only resource or the only source of reliable information about substance abuse history. Families have valuable information about who your client is as a person and how to frame a successful approach. But when you see us, we're usually not at our best. We may even seem more out of control than the person with the illness. So, where are families coming from? Families feel lost, overwhelmed, angry, or victimized when mental illness strikes. Mental illness is a severe trauma to the family. I would like to briefly introduce you to the emotional stages of recovery chart. This is the chart used in all of NAMI education classes and support groups and applies to every member of the family, including the person with the illness. These are normal and predictable responses that anyone goes through when dealing with any trauma, including the trauma of mental illness. Unfortunately, we're not able to see too well. But please note that mental illnesses are chronic and cyclical disorders. There is a roller coaster of ups and downs, crises, and better times. When you see us in crisis, families are usually in the first or second stages because we are also in crisis. We are in denial or angry and feeling great guilt and grief.
Yeah, thank you, Monique. So, as you see on your screens, the emotional stages of recovery, real quick. One is dealing with catastrophic events. That's crisis and chaos, shock, denial, normalizing, despair. And then some of the needs of those catastrophic events and dealing with that is support and comfort, empathy. And then they have for number two, learning to cope, anger, guilt and resentment, recognition and grief. And some of the needs to when it's learning to cope is we need to permit and vent our feelings, education, self-care, networking, to let go, to learn the system, and we need hope, right? And then when it comes to, then it's number three stage, and that's moving into advocacy. And some of the needs is for your to understand is the understanding and advocacy and action and acceptance. And some of the needs for that is to restore balance in life and the responsiveness from the system, to find meaning and a sense of empowerment, activism, and hope. So thank you, Monique, for that. All right, so next we're going to go over this section. It's called the Emotional Stew Emergency Personnel Walk Into. So not only are the officers going to be dealing with the situation at hand, they will also be dealing with the anger, frustration, and guilt that the family has, right? The family may be angry at the victim. They may be angry at the police because they feel like they don't do anything. They may be feeling frustrated or feeling guilty because they may have let things go far too long. There may be some frustration there because this is often not the first time they've had to call. There might be some guilt because this is their family member, right? And there's a lot of guilt and shame about calling the police on their relative. Some family members, like myself, and originally may think that it's their fault and the reason why their family member have a mental illness. So they're still trying to adjust to that and accept that. And then some family members may be embarrassed for calling outsiders who are wearing guns to come and take care of something that they feel that they should be able to handle. And as we know, there's also stigma in the community and people knowing our business, right? So here we go. We call the police and they come in force. We don't understand the issues of police safety and protocols. We just know that 4 police cars come, they park in front of our house where we lived at for years. Lights are flashing, radios are crackling, and our neighbors and our ill relative who reacts to loud noises see this and they hear the officers loud back and forth talking about our husbands and our sons, our daughters, and our loved ones on the radio, talk about coming out and letting the neighbors know about this shameful problem at their house, right? Everyone knows our business. So there's a lot of stigma around that too. And it could be a lot of trauma around that too, right? So many times the trauma of mental illness creates a lot of family conflict because family members, including the patient, are at different stages of emotional response. And they have different needs and tend to talk across and argue with each other about the problem, or even if there is a problem, and about solutions. You often have to de-escalate family members when you are trying to deal with the ill person. It helps to know what they need in their stage. Do they need empathy for their confusion and crisis? Because if you give them that, it can immediately deflate their anger and frustration. Families need, but do not generally get any specific information about the symptoms, treatment, what to look for, or how to cope. This does not necessarily change over the years. As stated earlier, 65% of psychiatric patients released from the hospital are released into the care of families. There is little attempt to help families understand, cope with, or plan for what they rarely realize will be a long-term issue and a family tragedy. It can especially be complicated, just like in the case of my son, when the family member is over the age of 18 or 21, they get released back into your care and you really don't have a clue or what they were diagnosed with, they were prescribed with, what's their plan of action, because of all the HIPAA and other protection laws in place. And so now you're dependent on them to tell you what happened or what the next steps are, but they often have no idea. They may be in denial or they're still trying to figure it out themselves. So lastly, people at all stages need reassurance that that it is not their fault, that others have weathered mental health crises, and that there are resources out there for them. And this is what originally led me to NAMI. I felt alone and had very little information and resources on mental illness. It was taboo in my family. We just did not talk about it. And so I started to Google and started to do my own research, which led me to NAMI. So here's some practical suggestions. Refer people to NAMI. Families frequently have no idea where to turn to for help, information, and support. NAMI is one of the best kept secrets around. For over 30 years, it has been advocating for better services, providing help, education, and support to families. Yet it always takes families a long time to connect with NAMI because no one tells them that it exists. NAMI's website, www.namimaryland.org, has available resources which gives you more information about NAMI. One of the free programs NAMI provides for families is Family to Family, a free 12-session intensive education course which provides information and skills that are exactly those I just said we don't get from treatment professionals or others. On NAMI's website, on NAMI's website, you will be able to access these free programs and other programs we have for families and for the person with the illness itself. If police and the community forwards a family to NAMI, the family will receive support and education, which increases the family's knowledge, its ability to cope, improves the relations within the family, and its ability to get help before a crisis requires police. It often reduces the family's need to call 911, and police are less likely to be involved in quite so many calls. Another tip is to engage in relative gets useful information and diffuses situations. So police officers are the expert on how to handle police business. Use your basic interview techniques, of course, but here are some practical suggestions from officers and families, what has helped culled from many conversations with families and police officers. These are very basic and common sense once you know where families are coming from. We know you know these tools. You use them all the time, consciously or unconsciously, but here they are, and you can use them in your role plays. Here's a few. So, partner with family first. Reassure them, reassure us, and get the information away from the person who is ill. Get the person who is ill. Reassure them that you are there to help and not to blame. Avoid an initial struggle for control with the family. The family feels out of control already, right? So everything is out of control in our house. Someone has to be in charge, but police cannot just walk in and do that by wrenching control away from the family. Police needs to work with family, right? Partner with family. Okay, example. Okay, you're giving us the info, so now we're going in and we'll be in charge. Another tip is safety always comes first, but then privacy and not public display. Another key point is display respect to the ill relative and the family, the same techniques you would use to diffuse other situations. And then try to de-escalate the family member away from the ill relative. Go to a different room or ask to meet the family outside. So this concludes this part of the presentation, and there's a lot of information. Monique is going to go over some practical tips for communicating with families again, and I'm going to end this presentation and pull up another one momentarily here. And let me just share my screen. All right, Monique, it's yours. You're on mute, Monique.
Thank you. Thank you. That might help, right? All right. Communicating with families. Where'd it go? All right. All right. So, what to tell the caregiver after the intervention? Wait a minute. I'm on the wrong one. Hold on for a minute. Please be patient with me. There we go. All right. Communicating with families. So, Remember, you cannot see that. Hold on. Do I?
It's on the screen
Okay.
though, Monique. Yep.
Yeah, I got it. So remember, families are useful information. We have useful information. So gather it away from the ill person if possible. Then you can use that information and say things like, I understand you've been taking some Medusa, so you pretty much, getting to know that person. So families are already upset. So please remember that. And we may be lacking sleep. So don't hold us accountable for things that we say out of our mouth, okay? All right. Also remember to give simple, concrete directives. And remember to be patient and please repeat the questions because we're not really thinking at that moment. We would like for you to de-escalate or lower the intensity. And you can do that by saying things to us like, you've really been going through a lot, or you're trying your best to help, or it's not your fault. Even these phrases can help de-escalate us because we feel like someone is listening to us. So the next one is collect the collateral information. Ask them to talk about what's happening now. So we know what's happening now. We don't want to talk about the past. We want to know what's happening right now. And then ask us what worked in the past so we don't repeat it and waste time. The next one, here's some practical questions. And these are very important questions. And this is not for police officers. This is anybody who may be in a position to help. So ask them, is there a history of mental illness or a past diagnosis? Are they generally violent? In response to what? When not taking medication? So have they threatened or attempted to cause violence to others now or in the past? Have they threatened or attempted suicide now or in the past? Have they been hospitalized before? Do they take medication? What medication do they take? Are they taking medication as prescribed? What dosage? Do they have some on them? Is the pill bottle in the house? See, you get all this information is very helpful. What do they think precipitated the event? And has there been any recent change, stressor, or traumatic experience? And lastly, on this one is, has subject neglected personal care or bodily functions? So here, those are some very good questions, but here's some other things to keep in mind. So after you've asked all those questions and things is kind of sort of de-escalating, so here's what we need you to tell the caregiver after intervention. So the subject was transported by the police. So this is what happens. So if you will be taking the ill relative to the hospital or elsewhere, please tell the family that they can meet you there or follow you or where you are going and what the procedures will be. There's nothing like when you're still in a state of confusion. Here's another situation. What to tell the caregiver after the intervention. So if the subject is not being removed by the police, if you cannot intervene any further or have already de-escalated everything and will not be removing the subject or the ill relative, let the family know that they are not the only ones dealing with the situations and that there is help. So here's the next situation. So what to tell the caregivers after another intervention or the same one? Whatever the outcome of the call, always give the family information. Always tell them about NAMI or BCRI. NAMI offers free family education and support, which improves outcomes and reduces calls for service. Free education course for curriculum based on families' needs. Free mutual help for the peer support groups for families, and free programs for the person with the illness and for the community. That they can now contact NAMI Maryland at 410-884-8691 or look for the website at www.namimd.org. So at the moment, this concludes our presentation, and that we will open the floor for questions.
Before we open it to you, Latanya, I've been looking through the chat and we have some rock stars in this. Thank you guys for all your encouragement
Yes,
for Monique and I. I'm reading through and thank you so much.
yes, thank you so much.
Up to you, Latanya.
All right, sure. I noticed Kara White's most recent post says, are they oriented to time, place, and event? Kara, if
Are,
you were,
are we
okay.
speaking about the NAMI workshops or training or?
So, Kara, if you want to add some more context to your question to the chat, that would be helpful. Gertie, I love awesome presentations. You did get a lot of wonderful comments, and even Kate came in earlier and made an excellent point. Getting the questions around reason violence does not mean you assume that the person will be violent. Getting
Right.
that information up front can just move you to specific response. So
Yes,
thank you,
thanks,
Kate,
Kate.
for that.
Yes.
So Kara updated, and what she put is what I thought she meant. The question she was referring to, um, that it's a question that can be asked when meeting with the family. Is the person
Mhm.
oriented to time, place, and event?
Thank you for that. In the Q&A, Heather asked, what are some of the quote unquote most and least helpful things relatives and friends have said to you about how to help your loved one?
Um, Most of the things that were not helpful was you didn't raise them right. We were
Mm-hmm.
blamed. It's something you must have done something to them. Uh, what did you do? It's really mostly the blame of the family. Is what did you do? Um, I very seldom got uh, any compassion or empathy of what's going on, and still a lot of them are in denial. And let's just face it, in our community, it's a taboo. So most of the time we won't even talk about it, and we
Mm-hmm.
just assume that every time a person is going through something that it's criminally related. What happens is that during the psychosis, some may go into criminal activity, and therefore they wind up in that situation, or they wind up in the hospital. So it depends on what's going on with that. But the family, I did not get any support until they realized that I wasn't backing down, and that I was very adamant on the education. And so those were the helpful things. Was was basically just educating them.
Yeah, and with me, same, taboo and really, not communicating and not being transparent about what they're going through and not empathizing. So, um, for me, although I recognize mental illness now that I know about it a lot more, long before um, I recognize it now, and that it's been a generations of it now that I know of it. But when my son started talking about it, and I started talking about it more with my family, helping them get involved and familiar with it, it's hard. This stuff is hard to talk about, right? You
Mhm.
got to have some kind of hope and courageous, because you're processing it, they're processing it, and your family's trying to process it. And some family members rather just ignore it, right? Because that's just the easy thing to do, until it becomes too bad, and then it becomes other people's problems. So yeah, we got to just continue to be transparent and authentic, and learn and be more educated ourselves, so that we can help ourselves, help our family members, and also our other family members to recognize those signs and symptoms. So since then, I'm able to talk to more family members and be transparent, and let's talk. Let's just talk. So it's been really helpful. Stewart and Yeah, Stuart, thank you. Howard County and Under Arundel have some good CIT training, I hear. So that's very good to hear.
It looks like we have another question that showed up from Valerie. Do you find that Black family experiences mental illness disproportionately and receive differential treatment by the medical and policing communities? How is NOMNI involved in erasing those disparities?
Well, we're here. We're African American. Just being education. Um, Education, training, peer-to-peer groups, family-to-family groups, basics. I mean, we have all types of classes. I know that one of the initiatives of NAMI in general was to actually be more involved and get more education out into those specific minority communities. I know that has been a priority for NAMI and in NAMI Maryland as well. So education, partnership with other organizations, partnership with schools, partnership with the police officers, partnership with community legislators. I mean, all of that is going to involve everyone to be a part of it, and that's where I think NAMI comes in as the experts, as the people with lived experience, and then we partners with the professionals who are out there in the field, and then we all kind of work together. But yeah, I do see the disparity because again, like Monique and I talked about, in our community, from my personal experience, and I'm not a doctor or a nurse, but from my personal experience, is that in our African American communities, therapy is coming a long way, but we weren't getting therapy. We weren't even trying to be address the mental health issues because we used the C word a lot, crazy, and it just, oh, he's just crazy, and just let him go, instead of actually getting to the root of some stuff. So, hey, work in progress, but I'm glad to see that we are moving along, right?
Thank you so much for that. There is another question, and I'm told to articulate to the group if you have questions that are time, we don't have time to answer today. I will put in the chat. Please send your questions and the name of the session you attended to connection@nomnimd.org, or submit your question in your end of the event evaluation later this afternoon. So I will post that in the chat in just a moment. And I have another question that came from Valerie. Do you distinguish families dealing with mental illness versus families in crisis?
Mm,
How do you recommend school staffs make the distinguish before calling police?
mm.
That's
That's good.
interesting because unfortunately, you may not always be able to distinguish that. And I believe that that's where education comes in. I actually had the privilege of being a substitute teacher in our local school system. And just the knowledge that I had made a difference there. And interestingly enough, the staff were like, how did you get the kids to listen? How did you do that? How did you de-escalate that was going on in the school? Because there was some stuff going on in that school that a lot of people don't realize. But recognizing traits, recognizing what mental illness looks like makes a difference in how you respond. And again, I believe the education, NAMI has the education for teachers, it has the education for medical professionals, for everybody in the community, depending on how you are participating. And so that's really the best thing that I can say is to get the education. I hope I answered that question.
So
Sharice, do
I
you?
wanted to read this. Yeah, you did. Thank you, Monique. You did
Okay.
good. I just wanted to read because Melissa had a great comment, and it says I saw an article recently that a police department, she couldn't remember the states it's in, but they have a database for patients in the community with mental illness. Isn't that something? The database has important family members, contacts, and information about patients' triggers, diagnosis, and any. So she asked the question: any law enforcement agencies in Maryland have anything like this? I don't think so, but I could be wrong. I'm not sure, but I'm definitely going to research more of that, Melissa. So thank you for sharing. And to respond to someone's question about we talked about the de-escalation, empathize. And then the more you know, and more you are, education is going to be the key word, right? The more you know, about mental illness, the triggers, the signs and things like that, you're a little bit more aware on what to look for and what to do and how to address. And that goes for officers, that go for families, that go for, just citizens. So de-escalation is definitely key to that. So Kate did answer Melissa's question. She said a number of mobile crisis systems connected with law enforcement do have such. So that's very good to know, Kate. Thank you.
And it looks like we had a couple of other resources. I noticed Stuart acknowledged one of our posts for a participant who shared words matter, terms to use and avoid when talking about addiction. So that looks like that popped up in our chat as well. A resource. So if you see that, you're able to access that resource. And then it looks like we have another post in our Q&A. Do you see a role for houses of faith, and how do you balance or integrate faith with the science of mental health work? And that's from Laura.
Oh, who is all up in our business like that?
I know, right?
Who is that? Okay.
Boy,
Go ahead,
boy.
Monique.
That's a whole nother session right there, people.
Yes, ma'am,
Oh,
or
my
sir.
goodness.
Yes.
Yes, exactly. So it is the role of the faith in mental health situations needs to change. And I am desperately on the path of working with churches, and if we can have seminars and things like that about mental health, because on a spiritual level, we talk about the spiritual aspects of it, and most of the time it's always demonic possession and it's things of that nature. And I'm not trying to preach to nobody, so I'm gonna try to work through this and just answer this question. And my argument is, I understand the spiritual side of that. However, scientifically, we are human beings, and just like our bodies get sick, our minds get sick. All right. And if we don't address that, whatever the sickness is, whatever that illness is, it will continue. It will get worse. And my argument is that you could tell me that I need to pray more because that's what I got a lot of. You didn't pray hard enough. You didn't do this. And I said, if I pray anymore, Jesus is going to come down and smack me and say, okay, look, I heard you. Just go ahead and just put into place the science that I've already put out there and use what you have. Educate yourself. We perish for the lack of knowledge. All right. So I can quote scriptures too. I can pull all that out too, but I'm not going to do all that. But here's what I'm going to say is that we need both. Mm-hmm. You can't have one excluded from the other. You need to have both. I'm going to continue to pray while my child is taking medication. I'm going to continue to pray while I go and figure out how to de-escalate this. What is it that I need to say? How do I need to communicate? Obviously, I'm saying something wrong. So you're working on yourself. So science is science. And the spiritual aspects of everything has to come together. That's what creates the whole person. You have to deal with the spirit, you have to deal with the mind, and then you have to deal with the body. So all of that comes together. So we cannot leave nothing out.
Thank you so much. Yeah. I just got a cue.
Yeah, but I just say Miss Gertie just in the queue, she just dropped the mic right here. She said prayer is a weapon, therapy is a strategy. Hello,
that's
somebody.
It right there. In a nutshell. That's it.
Oh, thank you so much for that. This time we have now, we just want to thank everybody for joining us today. That sounds like Sharice, that could be a t-shirt. I know some people have marketing ideas, put it on a mug, right? What Miss Gertie just posted. But this is all the time we have for now. We want to thank you